Okay, good morning, everyone. Welcome to our first morning breakout session of Psychopharmacology Basic. For those who don't know me, I am Dr. Pushpal Desarkar. I'm adult autism psychiatrist, as well as member of the Education Committee of Ontario Working Group, as well as the University of Toronto faculty course director for this conference. Um, we are so excited to have today with us Dr. Christopher McDougal, who is one of the international world expert in the neurobiology and neuropsychopharmacology of autism spectrum disorder and intellectual disability. He is currently the director of the Lurie Center for Autism at the Massachusetts General Hospital, and also he is the Nancy Lurie Marks Professor of Autism at the Harvard Medical School. For me, he's the expert in this topic. He has published over 700 publications, including original articles, case reports, and conference abstracts. He has extensive experience in clinical trials, and he is the recipient of numerous grants and prestigious awards. So ladies and gentlemen, here is your opportunity to hear from the top expert of this field. So please give your warm welcome to Dr. Chris McDougal.
Well, thank you very much for the introduction and the invitation to come today. Can you hear me okay in the back? Okay, so I'm giving two talks today, and they divided them into, they call this one basic and the next one advanced. I'm not sure what that means, but the content is very similar. I think in this talk I've tried to make it a little bit more practical and how you actually do it rather than theoretical and an overview of the literature. So if that's okay, we'll start that way. I don't have any conflicts of interest to disclose. I'm too busy at work, my day job, to do anything beyond that. And every medication that's used to treat some aspect of autism is off-label, other than the use of aripiprazole or Abilify and risperidone or Risperdal, which are FDA approved for treating irritability in children and adolescents with autism. So there's no medicine that's been approved to treat any of the core aspects of autism. So that's important to know. So I'm hoping you guys like Neil Young, but maybe I shouldn't make that assumption, but I love Neil Young. I love Neil Young, and he's a little bit different socially, honestly, as well. If you don't know that, I know a lot about him, but he bought a big ranch near San Francisco when he said once he became a rich, famous rock star, and the house on the ranch had 2 bedrooms on it, and someone said, well, aren't you going to build a big house with lots of room? He said, no, if I had more than 2 bedrooms, that would encourage people to come and visit me. And I have to admit, I feel very similarly. So I'm a nice person, but I'm not a highly social person. But that's just the way it goes. I feel like I can relate to my patients and their families very well. So, they really changed up the diagnostic criteria on us a couple of years ago. And I don't know if Dr. Volkmar addressed this or not. I know he has thoughts and feelings about it, and I tend to agree with him. But there was an advance, I thought, in the field in trying to subtype these disorders into something anyway, so we could begin to get a handle on different clinical presentations and maybe family history, and begin to understand treatments that might work for one subgroup or another. And then when the DSM-5 came about, they pretty much got rid of all of that and said, in my mind, they kind of said, let's start over. You know, we don't really have confidence in these different diagnostic subgroups, so let's just start over. But, you know, there's only so many times you can start over. Each time, it really hasn't led to any meaningful progress. So I was more of a fan of leaving things the way they are and continuing to sort them out. Because it seems like something changed. You hear me the same way? Can you hear me the same way? Yeah. One of the biggest challenges in the field is the heterogeneity, and which is why we have to know so much about everything we do, and we say things like, well, if everyone with autism is an individual. Well, that's true, but it doesn't really help us move treatment forward where there's some confidence and guidance in what you're going to do is going to work for this particular person. So the lack of an understanding of meaningful subtypes across the board from clinical presentation through cause is very difficult for us. And we can talk about that for a long, long time, but it's a big challenge, let's say it that way. In some ways, it makes it easier because when we had DSM-4, the resident would go in and evaluate a patient and come back and say, gee, Dr. McDougle, I'm not quite sure if it's autism or Asperger's disorder or PDD-NOS. Now they come back and they say, Dr. McDougle, yes, I think it's autism spectrum disorder. And I said, are you sure? And they said, well, yes, Dr. McDougle, what else could it be? You know, what's so hard about this? So I like to make light of it a little bit, but it's just, it kind of bothers me a bit. So just sort of the way we think about the approach to an evaluation, there are lots of different things that you need to think about, and it's certainly a disorder that needs a multidisciplinary approach. So psychopharmacology is just one element of what we do. And at the Lurie Center, for instance, we have child and adult psychiatry, child and adult neurology, developmental pediatrics, pediatric gastroenterology, adult internal medicine, neuropsychology, speech therapy, occupational therapy, physical therapy, social skills groups, educational consultants, college boot camps, vocational preparation, really anything we can bring, because each of those disciplines can contribute a lot. And I know very little outside of what I do day to day, so I need experts in these other areas to really do a nice job. The other thing that we do is we treat people across the lifespan. So we don't do an evaluation and then say, good luck. You know, we do an evaluation and we schedule your follow-up appointment. So when you do follow-up appointments, that takes a lot more time, you know, and it takes up room for new people that you need to see, and there's a pressure there. But our philosophy is to make a commitment to you for your entire lifetime. And, you know, there's a whole lot more that you need to do to help these people than a 30 or 60-minute office visit. The real work occurs outside of that time, and none of that work is reimbursed. So we wouldn't be able to do anything like this if we didn't have philanthropic support. There'd be no way. So we're fortunate to have the ability to do it right, if you will, or try to. And having a multidisciplinary team to talk about a patient is invaluable, as you know, but relatively rare to have that. So diagnosis is important. You know, in the clinical setting, we don't use any formal, fancy gold standard diagnostic instruments. That can take a long, long time. And I think that you can learn how to diagnose autism if you don't know how to do it. And some people have a natural talent in doing it more quickly, and I think better than others. But the place where you really need the formal diagnostic testing is in research settings. That's okay. But clinically, we do a standard, take a history and come up with a treatment strategy. And it's always taken me 2 hours to do a new evaluation. That's just what it takes me. I don't know if that's fast or slow, but it hasn't gotten any faster over 25 years. So I think it's probably about right. But I don't think in the real world that they reimburse people in the community to take 2 hours to do that. So what I would say to that is that then you're not able to do an adequate job, because I'm not a slowpoke, but I get the information that I think you need. So you need at least 2 hours to do a good one, and then talk about the treatment plan with the family and answer their questions. But I don't use any tools per se. Physical exam, I don't do a physical exam every time I do a new intake. But with these other providers, if someone, right away we learn that most of them have some kind of other discipline need, often medical, whether it's GI or neurology. So they're going to get a physical exam when I begin referring them to my colleagues. Neuropsych testing, I think, if the neuropsychologists are really good, can make a big difference. And particularly for educational planning, for determining overall cognitive functioning, so that the parents and the team have some idea of what the longer-term outlook for this individual might be. I think that's difficult for everyone when that kind of relative determination is made, but I think it's important to do at some point. Genetic testing, I think everyone should have a chromosomal microarray and Fragile X syndrome testing. And once you've done that, you've done your duty. You will have identified most of the possible genetic abnormalities, and you'll get in discussions like, is it going to change the treatment for the individual and all of that? Sometimes, not usually, but it may give you a sense of the life course of this individual if we know there are associated medical problems that arise down the line, and it may also be helpful with regard to relatives of the individual. We don't do neurological testing just for the heck of it, Many of these folks aren't able to cooperate with it, so you kind of need to be realistic and not too rigid and say, I don't know if this little boy's going to actually be able to hold still for this. Well, then they say, well, we'll give him general anesthesia. Well, you better think about the risks of all of that. So if there aren't signs on a neurological examination that point to major potential brain areas of problem areas or seizures, we don't routinely get any of those things. But on the other hand, you don't want to forget about those possibilities when you're trying different treatments that may not be working. You want to begin to wonder again about, this child's responding in an atypical way. I wonder if this is related to seizure phenomena, etc. So you want to have be able to see it from both directions. Treatment, again, really the kinds of things I went over that are important to offer. And I have psychopharmacology at the bottom. But behavior therapy, that's a term that encompasses a lot of different approaches. And I'm not an expert in behavior therapy. We have experts, but using ideas of consequences and rewards and things like that, I think makes some sense if the individual is able to understand that. We're not rigid around any particular approach, but it can certainly be very helpful. And I think in combination with medication can be very helpful at times. So we have the idea of using whatever might be useful for the individual. Speech and language therapy, extremely important. if 25 to 33% of these individuals are going to be essentially nonverbal when they grow up, I think it's important to try to do what we can. Much of the behavioral problem and the frustration results from a difficulty communicating. And I think it's important to not think about communication as only being accomplished through speech and language. So non-verbal forms of communication, I think, should be explored. It seems like some of these people, we work with a lot of adults that they had, if you will, standard speech therapy for years and nothing really changed. And so I think sometimes we need to step back and say, is this productive use of time? Are there alternative approaches we could consider? Because he really doesn't seem to be much different. Let's shake it up here and move beyond the things that we've take for granted and that we've determined to be standard approaches. Occupational therapy, very important for the sensory issues of these children. I think as providers, at least me and others I know, we never made much of the sensory problems. Parents have been telling us about them for years, and we would hear it, but we didn't really know what to do with it. Now that the sensory issues are part of the DSM, I think that's been a useful addition. People are doing more research on what might cause sensory problems. I think if you refer these people for occupational therapy, then it needs to be a referral to someone that understands sensory problems rather than routine occupational therapy needs. And I don't know how common those kind of people are around. You have to sort of look for them, where I'm at, people that do it day to day. Physical therapy, most people with autism do fine physically. They don't need physical therapy. If someone has major neurological or motor problems, you need to start wondering if it's really what I would call primary autism, if you will, or if their social impairment may be due to something else, some kind of neurological event that contributed to the brain problem, the social impairment, and a motor problem. But most people with autism don't have major physical therapy needs. Social skills therapy, I think, again, a lot of this we don't have algorithms that mean a whole lot. We kind of try things, but is it useful to do it in a group? Is it useful to do it individually? Is it useful to just do it in a clinical setting but not then go out into the real world and do it? All of these things are up for discussion. It's, in my opinion, the social impairment is kind of what autism is about, the social communicative impairment. So you're going after the toughest piece of it, if you will. At least it's been tough to move it, to change it in a prominent way with most of the therapies we do. It's interesting, if you look at what used to be called the core symptoms of autism, social impairment, communication impairment, repetitive behavior, there isn't one drug that's been shown to work for any of those things. I mean, that's kind of striking. Think about the disorders in the DSM that define them. And treatments usually help with the major symptoms. Think about depression, schizophrenia. They make the defining symptoms better, almost in all of them. Autism, none. What's that mean? We probably shouldn't think about it too long, or we might have to redefine everything, but it should tell us that we need, this is really something we've had tried to think we've had a hold on for a long time, and we really don't. Think of it that way. I think I'm not a fan of this spectrum concept for any disorder. I guess that's part of being an investigator type guy. We're not supposed to lump, we're supposed to split. And a spectrum is certainly a lumping phenomenon. I think it gives us a nice feeling, like, well, we've got a handle on it now. He's on the spectrum. I just don't like to hear that. It bothers me a lot. It makes it too simple. It's better to say we really don't know much of anything. we had a lot of work to do. And that, I even told our faculty, I said, you're no longer able to make a diagnosis of ASD. That's all we do, basically. Well, what do we call it, Dr. McDougal? I don't know. Say, I don't know. And then figure out what really caused it. Yeah. Well, how do we know what really caused it? Give it your best guess. Because if you take a detailed history from conception throughout, there are going to be a number of events that may have contributed to it, right? Potentially. If you take a detailed history. And I said, take your best shot at what you think it was. And then we're going to have a bunch of people that cluster into potential likely causes, different buckets. Then let's take a look at the patients and see if they sort themselves out in any way. But it just bothers me to have an assumption that we have our hands around this. Okay, it's distressing to me. But I'm never satisfied with anything in life. I'm getting tired of that, but I can't help it. Anyway, I'm trying to give you a sense of the way I think a little bit. I'm not trying to be provocative by any means. I'm just telling you the way I really think after having done this for a long, long time. Special education, I think, very important. Again, all kind of different approaches. If you have the wrong school setting, the wrong approach, it can exacerbate behavior. It can be terrible. And you're trying different treatment approaches, and it really is the school. Or they're trying to educate a person whose brain doesn't understand the way they're trying to educate. And that's got to be extremely frustrating. So I don't minimize the importance of any of the disciplines, because I think they can all make a big difference if they're in the hands of someone that knows what they're doing. And at some point, everyone needs to eventually say, in a relative sense, is this going to be a person that needs a focus on life skills or post-high school education? You got to at some point make a decision and allow some time for that, because it's going to affect, there are a lot of people that are going to be invested in different pathways for different reasons, and that's okay. I think it's always important to try to challenge the person rather than give up. But there becomes a point where too much challenge leads to behavioral problems and self-esteem effects and all of that. Comorbid medical problems. So some of them that we see commonly, GI is certainly high on the list. Now, I work at a place where there's one of our doctors is named Tim Bowie, and he's kind of a national, international guy on the relationship between GI and autism. So I think that affects the referral to our center. We see a lot more of it, but I can tell you that we see a lot of it. And when I was at other centers, we didn't see very much of it. But there we were based more in psychiatry, and they didn't tend to come to us for more comprehensive care. But GI problems can be very problematic, and can make a big difference in behavior if they're addressed and treated. Seizures, I think you're all mindful of, and about a quarter of people will eventually develop seizures. You're always going to have the child that has staring spells and not know if it's what it is. But if it persists, then ruling out a seizure is worthwhile. The other thing that's interesting about seizures is there are two peak ages of onset, really. There's early childhood, and then there's late adolescence, early adulthood. And in my experience, the early childhood are more often linked to what I kind of think of as just a bad brain, if you will, where there's some kind of neurological damage or more likely identifiable. And the later onset seizures are more in a classically autistic person where there aren't a lot of other comorbid medical problems, and then boom, out of the blue, grand mal seizure, and they're in the emergency room. So it's frightening to everyone, but it's not unusual. So you need to have that in your mind when it happens, that, okay, well, this is something that occurs. Let's get an evaluation and see if they're going to watch this or start an anticonvulsant, but that can be relatively common. What that tells us is there's something very important that happens to brain chemistry over development in a subtype of people, and we don't know what that is yet. But that's the kind of thing that would be important to find out. So that's something that needs additional study. Vocational training. Yeah, I mean, I guess I have opinions on a lot of this stuff. It may not be fact, but there's often that tendency to say, let's try to align this person's special interests with a vocational interest. That makes sense to me to start with. It may not always work. Things that make sense aren't always true and don't always work. But it's a reasonable first step. The challenge is finding someone on the other end that's receptive and patient and willing to work with the individual. It's hard, I think it's hard to try to talk to a patient with autism that has extreme latency in their verbal response. You know, we're all busy. You ask a question and they look at you, they're processing it, and it takes 30 seconds before them to say something every time. The way at least my world is fast, and I have to really work at it. I empathize, but at the same time, time's ticking. So think about people in the real world that would have to try to interact with a person like that. It could be challenging. So it's more our fault, if you will, I guess, neurotypicals, than their fault. But there's more of us than there are of them. So that's why it makes it hard for them to live in our world at times. And then medication, you know, I guess that's what I'm supposed to talk about today. So I got to that finally. But part of that's intentional to say that there's a whole lot of other things that are really important. And then if these things aren't helpful, sometimes we need to use medication. And you shouldn't be anti-medication if you've never seen it work or never tried it yourself, because you can be a convert. So what makes me say that, you know, I see a lot of the patients I see come with their parents, and usually it's the mother. And mothers of these kids are, wow, they are stressed out, and I'm not minimizing that. I understand it, but they're often highly anxious or depressed or both, and they're not always aware of it. And I try to point it out if I see it, because I kind of look at myself as like a family psychiatrist. You know, everybody in the room needs something, and if I can improve a couple, then everybody gets better. But some of the mothers that are coming to my mind, you know, now I'll say, you know, how are you doing? And their tears are this close to the surface, and I know if I ask one more question, it's over, or I could choose not to. So it depends on the situation, but it's right there. And, you know, they're so busy helping everyone else in the world that they don't feel they have the time to address their own needs, certainly not their mental health needs, but let alone everything else. So I often, if I've seen them a couple times and I have a relationship, I'll say, why don't you come in and see me? Oh, you know, I tried that in the past. Okay, well, and you can make a huge difference if you can get someone that comes in, well, kind of what I would call just kind of straightforward major depression, if you will, that can really respond to treatment, and everybody's much happier. So I think it's important to be open-minded about any treatment that might work. Okay. Somebody slipped in an extra slide. Here we go. Target symptoms. So this is the way I think about it. You know, do I try to make psychiatric disorders in people with ASD? Well, relatively speaking, but in the end, it's more symptoms. Because sometimes maybe it makes you feel better to say they have bipolar disorder, to describe irritability and cyclical behavior. If it makes you feel better, that's okay. I'm back to I'm not so sure. Let me just say what it is. Okay, I don't feel that need sometimes. Well, if you don't have a diagnosis, how do you know what to treat? In ASD, there's none of those algorithms, so I treat symptoms And I use things like family history of psychiatric illness to try to inform me, particularly about things like bipolar disorder. But it's very difficult to know if someone is psychotic or not, for example, many times. If they can't talk, there's no way you know for sure that they're psychotic. There's no way you know for sure. Now, there are people in the world that are more, risk-taking, and there are others that are way cautious. And I probably lay on the side a little bit more toward risk-taking, not dangerous, but some people would say, well, how could you treat it with an antipsychotic if you don't know they're psychotic? I would say, well, how can you not treat them when you look at what's happened to their life at the age of 18, but they simply can't tell you if they're psychotic? So there comes a point where you need to have some confidence. You're not going to hurt anybody if you do it in a cautious way, but you could do a lot of damage if you don't treat and you just watch. So either you have to have some confidence yourself or send them to me and I'll help you. But I feel pretty strongly about that. You're never going to know for sure. But let's look at these things. I call them what you want. Symptom clusters, target symptom domains. Those are the kind of terms we use that make sense to me. And you've got this cluster of motor hyperactivity and inattention, usually impulsivity. And let's start with that. Well, the first thing you could say is that ADHD, Dr. McDougal? I said, well, I don't know. That's why it doesn't say ADHD. It says what the symptoms are. And because not everything that's hyperactive is ADHD, we know that. In a little bit, we'll get to repetitive. Not everything that's repetitive is OCD. Most of it isn't, in fact. So, and then if DSM-4, when it went to 5, how much time did it take for that to happen? It took 1 second, right? Because it began on a certain date. So at midnight, when it hit 12:01, DSM-5 was here. It took 1 second. Now, in DSM-4, you weren't allowed to diagnose ADHD with PDD. Now, you did it, but you weren't supposed to. It said you can't do that. And within 1 second, you could do it. I point that out because, again, it seems silly to me that something that people take really seriously like that could occur in a second. It's not that important. All right, it's reshuffling the deck for some reasons. The same kid in the office, All right, so I don't get hung up on that kind of stuff. I'll just say, well, that whatever you want to do is fine. Okay. I won't get into the Republican debate from last night, but it made me think I'm more like Donald Trump than some of the others. But I don't know if that's good or bad. He says, politicians just talk all the time. They don't do anything. I mean, that's kind of the way I feel about a lot of stuff. Especially, I won't say the highly intellectual institutions I hang out at. Because I'm originally from Indiana, Midwest, Okay. Sometimes I get feedback on these talk, he's flippant and all of that. I don't mean to be flippant or dismissive. I really don't. I just like to tell you what I think and make it a little bit entertaining. I can give you a very straight up, boring intellectual talk. I can. But I wouldn't enjoy it either. So don't say I'm too flippant or anything in the evaluations. They send it back to you and it bothers me. Now that'll make some of you underscore it, or highlight it, but that you can't win everybody over. So here comes motor hyperactivity and inattention. So if it was a child with what I'll call straight up ADHD, a stimulant is the most effective treatment. There's no question about it. The gold standard treatment. And I think of stimulants as being in two different columns. There's the Ritalin column and there's the amphetamine column. And they're all different kinds of names for those things. The Ritalin has Ritalin methylphenidate is the basic generic compound, Focalin and Concerta and Metadate and Ritalin LA. There's a whole bunch of them. They're all the same compound with different durations of action and all of that. Then the amphetamine side, you've got dextroamphetamine and Vyvanse and Dexedrine and Adderall. So there are really two different categories that are different. If one doesn't work, it doesn't mean the other side won't work. So, and you can find out pretty quickly if a stimulant's going to work. So it might be worth checking out both sides rather than coming back later on. The most difficult symptom to treat among this group in ADHD, in ASD, is inattention. Because I can treat hyperactivity with a lot of things. I can put you to sleep, if you will. I mean, you can, but inattention, and it's, you don't, the problem is we don't really know if it's inattention. So here I am, a child in school, and I'm going like this. And I could be doing all kind of things. I could be having a seizure. I could be counting things on the ceiling. I could be thinking about a preoccupation. You know, it kind of looks the same though. So we make a call on it and we do our best, but it may not be whatever inattention is as far as an ADHD-like symptom. So our hit rate with drugs is going to be not great. So stimulants, let's go through stimulants in a little bit more detail. What's the good news? You can find out if they're going to work pretty quickly. So how do I do it? I say let's start with generic Ritalin. That's just what I do. 5 milligram capsule. Let's start it on the weekend because it could make the child worse. Let's don't do it on a school day. Saturday morning, give 2.5 milligrams. At 12 noon or 1 o'clock, give 2.5 milligrams. If nothing happens, on Sunday, give 5 and 5. So I increase it by 2.5 milligrams at each time point, each day, until we see, wow, he seems to be doing quite a bit better. Let's stay at this dose and let Dr. McDougal know and go from there. Okay. Or he's worse, right, pretty quickly. What would worse mean? Making the symptoms you're trying to treat increase. More irritable, more hyperactive. It could be that direction. Extreme insomnia, right? It's a stimulant. Weepy, tearful, depressed. You could see that in some kids. The emergence of tics, right? Eye blinking, shoulder shrugging. Those are all side effects of a stimulant. Or you keep getting the dose up to the dose that we told them, don't go beyond this, go to this dose before, and then check in, and nothing's happened, you know. So, but within 10 days to 2 weeks or less, you're going to know, which is, I think, nice, you know, because the most effective treatment for inattention is going to be a stimulant, but you have to be lucky to get the child to tolerate it. But why not check it out quickly, because you can get in and get out. Now you could say to me, do you start with a stimulant? And I'll say, no, I don't. And you say, well, you sounded like you were kind of saying to do that. I probably was, but I don't do that. Why not? They may have waited a while to see me. And here they come. They have high expectations. We finally got in, you know. And it doesn't mean a whole lot. We'll do our best, but it's not going to be a guarantee. But I don't want to start them on a stimulant and in 2 days things are worse, because it disrupts the therapeutic alliance, if I can say that. And I don't want to do that early on. So I'd rather start with a different medicine that we'll get to in a minute. So stimulants, in and out quickly, side effects. The other thing is the short-acting forms you have to give more than once a day. Well, some kids, it's a battle to give a drug every time. It's a battle. It's not worth it. The other thing might be, does that mean he has to take it at school? Yes. Well, I don't feel comfortable with that. Okay, that's important to listen to. You can't give a stimulant. Let's just give it at 7 p.m. at night when he gets home. You're going to disrupt sleep. So you have to think about all of these things. I think about them as like diet pills, if you will. Like, then you know what the side effects are. Reduced appetite, cause you stay awake, that kind of thing. The other is they're controlled substances, at least in the U.S. I'm not geographical very much. I don't get around too much. So you have to bring in a new prescription every month, a hard copy. You can't fax it. You can't give refills because you can abuse it, you know. So there you're going to be off the drug for periods of time because they didn't have time to come and get it. We mailed it, but it didn't get there. So But what I often do is start with a short acting, and if it works really well, I'll switch them to a long acting form, where you do same dose, give it in the morning once a day, and that can solve a lot of problems. Some of the things you can run into then is, well, what if it wears off early? They really get irritable. You got them through school, but homework's a nightmare. Now you got to just think common sense. Well, first thing I would probably do is, can I increase the morning dose and get it to last longer? All right. Then let's say it's still occurring. Well, maybe I can add a little bit of a short acting when they get home from school to get them through homework, but not disturb sleep. So you have to just use common sense a little bit. You always want to err on the side of caution with any medicine. The starting dose for me of any drug I use is as low as I can get. Well, why wouldn't you start higher? It doesn't mean it'll work faster. It means you're more likely to have side effects. Well, that's just a baby dose, Dr. McDougal. You have to cut the pill into quarters. You don't have to listen to me. I'm just trying to help you. I don't make it complicated. Well, what's the half-life? How long should we give it before we increase it? Increase it every week. Once a week, how much? The same amount you started on. That's easy. Lowest dose in a week, go up. Next week, same answer. All right. How high do you go? Until it works, they have side effects, or you've reached the maximum dose. Well, I don't know if I feel comfortable going that high. You're not at the highest dose. They don't have side effects. You're in with the drug anyway. You might as well use it. Well, I'm a pediatrician. Doesn't matter. Common sense. I mean, if you're going to use it, then use it. That doesn't mean aggressive. It just means try to get them better so that it's an adequate trial. All these guys come into your office. I've had every one of these drugs. And then you start taking a history. How long were you on that? 3 days. Didn't work. Look at all the work we got to do, man, to make up for lost time. Give them an adequate trial. Well, it doesn't seem like it's working. I'm going to shut it off early. Don't do that. You might not be at a dose that the brain recognizes. So patience is the most important thing in psychopharmacology. Speed does nothing. You can't make it go faster. That's very important. So pros and cons of stimulants. All right. Alpha-2 agonists. So these are things like guanfacine, which is 10x, clonidine, which is catapres, and now they have some long-acting forms of those. So the long-acting form of guanfacine is Intuniv. Give it once a day. It lasts all day. Capve is the long-acting form of clonidine. Now you're into another problem, potentially, is the long-acting drugs are in a capsule, and you're not supposed to chew the capsule because it's released at a certain way. So, and the other problem, a lot of kids can't swallow pills or don't. So that cuts into your ability to use an extended release formulation. Now, sometimes if they want to chew it up, but they get it in them, I don't care. You could do that. But if they can't swallow it, you're not going to get anywhere, all right? Some capsules you can open up if they're not extended release and sprinkle it on food. But you have to know a little bit about what you're doing, I think, in there. So in this category, I usually start with generic guanfacine. And it comes in 1 milligram tablets. I said break it in half. Give a 0.5 milligram in the morning. How long? Well, how long do you think I'd give it? A week. What do you do in a week? I go up by 0.5 pill. When do you give it? I give this one usually in the morning and when they get home from their day, like 3 or 4, whatever it might be. And I go up by 0.5 milligram, 0.5 pill every week until they're better, they have side effects, or I reach a maximum dose. What's a pretty high dose? If I'm getting to a total of 3 milligrams a day, that's a pretty solid dose. It would be rare for me to go above 4 milligrams a day. But at 3, you're into a solid dose. And what are the side effects? Sedation. But the deal is, it wears off. So if you get a call after 3 days and he's sound asleep, say, whoa, 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 whoa. Let me back down and start you at a quarter of a pill. Don't give up, because this is going to help many times. And then go up at a slower rate. But if they have sedation, it's usually going to wear off in 3 or 4 days. And then they're going to be like, it's not working. And then you go up again, see. So sedation that's transient, it's a blood pressure pill, so it can lower your blood pressure and your heart rate. Dr. McDougle, do you have them come in every week to take a blood pressure? No. Why not? Well, experience tells me there's not going to be a big effect on it, increasing it at this rate. Okay? So I don't worry about that. At the doses I'm using and the rate, I'm not concerned about it. I'll get a baseline blood pressure and heart rate, but if it's okay, I'm not going to be too concerned. Do you get an EKG before you start it? No. I used to, but then the cardiologist told me, why are you doing that? Okay. You don't need to. Now, you can never be blamed for being conservative. I would never say that. I'm just telling you over time what I'm comfortable with. If you want to be more conservative, you can be. The other thing that it can cause is constipation. So you need to be aware of that, because you might not think of it. And if that's already an issue with the kid, it could become a bigger issue. That's about it. So there's no long-term side effects. That's what I start with. What percentage of the time does it work? At least 50%, which isn't bad if that's the first treatment you've gone with. The main thing, it doesn't make people worse generally, like a stimulant could. So I'm either going to help them or it's just not going to work or work enough. It generally is going to be tolerated. So I think it's a good place to start. What about clonidine? So clonidine's in the same class. It's also a blood pressure drug. It's too sedating. It's more sedating than guanfacine, and I don't want to put them to sleep at school. So we'll talk about medicines for sleep problems later, but I don't use it routinely for ADHD symptoms. Here you can give refills, so it's not a controlled drug. That's about what I have to say on that. Non-stimulants. There are a couple non-stimulants. So the alpha-2 agonists, those are non-stimulant treatments for ADHD, but so are these, atomoxetine or Strattera. So that is it's made by the same company that made Prozac. Prozac's a selective serotonin reuptake inhibitor. This is a selective norepinephrine reuptake inhibitor. Same mechanism with the norepinephrine. And if you're a real child psychiatrist, or psychiatrist, which I guess most of you are, I'm not. I just do this. So I don't know a lot about treating other things, but you treat a lot of regular ADHD. You might say, oh, this stuff, it doesn't compare to a stimulant, because you've got that experience. That's probably maybe what you think, what I hear. But in my world, if stimulants work 25% of the time only, because the rest of the time they're making them worse, relatively speaking, some of these other drugs might look a little better. You see what I mean there? So it's not so bad. If it works a quarter to a third of the time, it's right in there with the stimulants. So what's the starting dose I use here? 10 milligrams. It's the lowest dose that I'm aware of. It comes in, and I go up by 10 milligrams a week. It's the same story I had for you. What are the side effects? There aren't a lot of them. Sometimes it can cause behavioral activation. It's known to affect the liver at times. You might want to get baseline liver function tests. I wouldn't go overboard in repeating it unless there were reasons. The other thing, the difference from stimulants or alpha-2 agonists, it's going to take longer to know if it works. So it's more like using an SSRI, where you have to go up on the dose gradually and sort of see. But it can certainly be an effective treatment for particular patients. I think it's better for inattention than the alpha-2 agonists are. You're going to have plenty of time to ask questions later, I believe. So, another non-stimulant treatment for ADHD to consider, bupropion or Wellbutrin. You know that one. What's Zyban, I guess. Now, one thing I want to point out is the way this is spelled. and pronounced. Because a lot of you, maybe, I don't know, 20% of you say it incorrectly. I'm trying to help you. So there should actually be another R in the word. There should be an R after the last P. It should be bupropion, because it sounds right. But it isn't. It's bupropion. You have to think harder to say it. So it's almost like, did he misspell that? But that's truly how it's spelled and pronounced. So there's two of those like that. I'll tell you the other one later, but I want you to say it right. This is a drug that, it's possible that you could say it works by increasing brain dopamine. That's the way I like to think about it. Because there aren't any other drugs that really do that. And dopamine's the chemical of reward, right? It's, wow, pleasure, energy, motivation, interest, drive. So you can think of certain types of depression, for example, where that would be the drug. It's also one of the few antidepressants that doesn't cause increased appetite. And a lot of people you want to treat for depression don't want that. They'd rather be depressed than take a drug that increases that. I understand that. So it's a drug I use a fair amount of in adult major depression. And it doesn't cause sexual dysfunction. But I don't use a lot of it in ASD. I don't think it's a great treatment for ADHD symptoms, honestly, compared to the others I've talked about. I will use it sometimes to treat adolescent depression, in higher functioning people with ASD. I guess I put it here just to be a little bit more complete. The thing to know about it is it can lower the seizure threshold. That doesn't stop me from using it if the person's never had a seizure. I don't get an EEG or anything. If they've had a seizure, I don't use it. So that's about all I'd say there, I think. This is getting back to when some of you know what these drugs, tricyclic antidepressants. So kind of the first group of drugs that worked well to treat depression, Elavil and Pamelor and all that stuff. Again, I wouldn't use these to treat ADHD, unless it was way down the line and there was a certain reason. They have a lot more side effects: dry mouth, blurry vision, constipation. They can affect the heart rate. But I just put it here again because in the old days, some people used these to treat ADHD. They may still at times, but the young people they're not into that. They all want granite countertops. You ever watch those shows? It means you're old, I guess, but House Hunters or whatever they are. There's a couple of them that I think are particularly set in Canada. Which one? The dark-haired woman, is she on that? I love that show. But I don't want to make fun of the younger generation. It just means you're old. But the young wife goes in and she's like, this has to be gutted. And the husband's like, and this is not acceptable. What do they call it? It's out. It needs to be updated. Or granite. Boom, boom, boom. Well, that's sort of an entitled approach to me. I don't know. I don't like it. But I think some of you can understand what I mean anyway, especially if you like old things. I like old mansions. Old mansions. Why would you ever tear that out, Anyway. So Joni Mitchell, these are all people with a Canadian link. You had a lot of really good musicians. In fact, I want to know where Neil Young would have hung out in Toronto. I'm not kidding you. Tell me. You ought to know. Yorkville. And where am I now? Am I like South Central? Where am I? Like if this is Toronto, make it up. Where am I? Down by the water, sort of? And where's Yorkville? Huh? Higher than the middle? It's in walking distance. Huh? Well, can you tell me the name of a club I could go to where he might be? Huh? There's got to be one. Like where... Well, Haight-Ashbury is still in San Francisco. I mean, it's kind of beat up, but... No, was there a place called the Cellar Door that he played at? I'm going to look for the Cellar Door. Well, where should I go then to be sort of like that? What part of town? Huh? Screen, Queen, and Ronceville. Point to it. You are here. Point to it right there on that thing. You are here. Artists, galleries, old record stores. All right, well, that's where I'm going then. Okay, they want me to pick up the pace. So, ritualistic behavior. So I do have feelings about this. Before I did autism, I did adult OCD. And I mean, I did quite a bit of it academically. And so I know it. And it's actually what got me into autism was through the repetitive behavior link. And we know that the only class of drugs that works consistently to treat OCD is SSRIs as a monotherapy. That's it. These don't work, generally speaking, for ASD. And that's because it's not OCD. So when they go like this, that is not OCD. So this is a whole 2-hour talk. The differential diagnosis of repetitive behavior and repetitive thoughts is really a fun talk. But this is called a stereotypy. This is voluntary. I'm doing it. It's non-purposeful. A compulsion is voluntary, but purposeful, if you will. A tic is involuntary, non-purposeful. The repetitive movements of temporal lobe epilepsy, a seizure, are involuntary, non-purposeful. And there's one more. Extrapyramidal symptoms from a drug are involuntary, non-purposeful. So not a compulsion or a stereotypy. We don't want to, people with OCD don't want to do a compulsion. These guys want to do this because maybe it makes them feel calmer. So the families are going to come to you and say, I need help with his OCD. And I'm not rude about it, but I do redefine it for him. Because if you think OCD, you're going to think a treatment. And these treatments don't generally work, particularly in children. So the large studies that have come out more recently, drug versus placebo, 12 weeks for repetitive behavior in autism, no drug placebo difference. And there's a lot of behavioral worsening. In the adult studies, they seem to work a little bit better for repetitive behavior. Now you might say, well, can you ever have OCD and autism? You can, but you have to kind of really know what you're doing and think it through. If you can't talk, you can't describe obsessions. That's just the way it is. So it would have to be an observed behavior, ordering and arranging, maybe. Again, is that pleasurable to the person? Often. Is it pleasurable to a person with OCD? No. So these terms ego-syntonic and ego-dystonic, they get in there. It's hard to stop somebody from doing things that are rewarding. Think about it. Drug abuse is really tough to treat. And carrying around a stack of books for some people is really rewarding. I got a guy that comes to see me like that. And you're not going to stop it with a drug. He's happy. I mean, we don't do it, but he does. So you got to change your mindset if you're using OCD in your mind a lot, because it'll lead you down a path that's not going to do much. Well, what if it's interfering, you're saying? Well, it's interfering to us. Maybe not to them. I know, but they live with us. I know. I understand all that. But they have needs that we don't. They like things to be all or none, black or white. So if there's a little rip in the paper, well, you're never going to fix it. The only way to make it all the same is to take it all off. If you think that way, a lot of what they do makes sense. They don't want the chair pulled out like that, right, by you. Well, I don't like it either. Would you push it in, please? I might trip over it or something. No. But, they go through the house and align things really the way things are supposed to be. And I'm not making a joke on this so much as that we have more flexibility. But if you think like them, man, they're so anxious if it isn't the way it needs to be. You can theorize about why, we don't know, but to me it's kind of, there's enough chaos going on. I want to make as much of it the same as I can, so I don't have to worry about it. I'm going to park in the same parking space every day, even though it's far from my building and there's no cars in the way. That's what I do. Why? I don't have to worry about where it is. What if someone parks there? I'm not happy. I'm the boss. It doesn't even have my name on it, but you ought to know where I park. So try to get rid of that. And don't reach for these if there's interfering repetitive behavior. You say, well, what do I reach for? I mean, you could try behavioral approaches. Most behavior therapists will tell me, though, that this stuff doesn't really get better for them either. Well, I have to try something. Well, these things at least are safe. So you could try it. Start at a low dose because you don't want to get behavioral, but don't be overly optimistic. I can get some of this stuff better with antipsychotics, but do I want to get into that? It depends on the level of interference and severity. There's no right or wrong, but I guess I'm trying to, the take-home message is we don't have anything that works consistently for this prominent characteristic core feature of ASD, which is interesting. So I think I've said most of this. They may work better in post-pubertal than pre-pubertal. Same side effects you might see in other things. Some sedation, some insomnia, some GI upset, sexual dysfunction. You can usually give them once a day. You always need to be mindful of the potential to increase suicidal ideation with any antidepressant. And you can certainly see it in people that can tell you about it. And you should ask about it because they will do it. So everything that can happen to us can happen to them. Aggression and self-injury. So I see a lot of that, right? Aggression toward other people, self-injury, property destruction, tantruming, meltdowns, whatever you want to call it. The bigger the person is, the bigger the hole is in the wall. I say that again to make a point. When they're little, you can pick them up and carry them out of the store. When they're big, forget it. And the parents are often I'll use the word embarrassed. I can't think of a better one right now. Everyone's staring at them, It's a nightmare. So people that work with little kids with autism, they think they're so cute. I understand all that, but they're not cute when they're 40 and they're nonverbal and they're head banging and there's blood all over. And I like to say that because this is a serious illness. This is serious business, and they're going to grow up, and it's not going to be a pretty scene. Anyway, cute and all that, I have trouble with that one. But I'm not warm and fuzzy. You can say cute, but I know what you mean. So the most effective drug treatments for real aggression, antipsychotics. There's no period. That's where you go. Let's talk about them. So the old ones, the typical antipsychotics, also called major tranquilizers, they work by blocking the dopamine 2 receptor. You know what they are: Haldol, Navain, Mellaril, Thorazine. They can work. Haldol is a very well-studied drug in autism. At low doses, 1 milligram, 2 milligrams a day, it works for symptoms of, we call it irritability. The problem is the potential for side effects. These guys are going to be on these drugs a long time if they have serious aggression. So the risk of developing abnormal motor movements, tardive dyskinesia, is high. They can cause weight gain, etc. So it's rare that I would use a typical antipsychotic. I will on occasion. If I've gone through everything else, I probably Haldol, just because I'm probably the most familiar with it. Again, start low and go slow. What about the atypical antipsychotics? A few comments on each of these. You should never ever use clozapine in ASD unless it's an extreme case. And the only time I use it is if I have a patient where I have what is called catatonia, and I'm positive it's catatonia. And there's only been 3 or 4 cases like that in my life. But this is a whole different bird, man. And I didn't think it existed until I saw it. It's pretty scary. They're very impaired. The other antipsychotics make it worse. So that you quickly become handcuffed with options. And if you read the literature, it'll say use high-dose benzodiazepines. You can try that. You should try that. I've had people up to 15 or 16 milligrams a day. These guys I've treated, though, didn't make a dent. They're not tired. Then the literature will say ECT. Well, you can do that too. You have to figure out what are you going to do after the course is done to maintain it. What are you going to do if they have to cross state lines? What are you going to do if they're intellectually disabled? So the clozapine can be very helpful in this condition. Let me just tell you that. And I don't know that there's much in the literature on it, at least in ASD. But you want to be very careful because then you're into weekly blood draws, right? And knocking down the white count in someone that can't communicate, they don't feel well. But if you have an extreme refractory case and this person is essentially dead, if you will, that's something to at least know about. So we talked about that. Weight gain. It's the most likely antipsychotic to lower the seizure threshold too. So you're another issue there. Risperidone, FDA approved, well studied. It works 60 to 70% of the time for irritability. What's your starting dose? 1/4 milligram, 1/2 milligram a day. What if they're an adult? Same thing. Size doesn't affect my dosing. Lowest dose possible. What if they're really sick? Go faster? No. Keep your fingers crossed, So any drug that works has to have side effects. Drugs that don't have side effects don't work for treating real aggression or psychosis. Forget it. Well, I think I'm having great luck with gabapentin. No, you're not. Not for long. Not for long. Not if you're treating psychosis or real aggression. Well, I've got this one case. Maybe so. Check your diagnosis. I mean, it makes sense. If you got symptoms that are like that, you got to hit it. And drugs that work for these conditions have side effects. So the ones with risperidone, increased appetite, weight gain. Like I said, if you're bigger, the hole's bigger. It can make things worse. If you're starving and you can't satisfy the drive, it can lead to increased behavior, particularly if food had ever been used as a reward and now you're withholding it. It can increase the prolactin levels, right? Breast swelling, milk letdown, effects on bone mineralization, sedation. But if you have a guy and it's right now, take this drug or we need to go to the hospital, one or the other, it's probably the one I'm grabbing right now. Olanzapine or Zyprexa, not as well studied. In my hands anyway, in kids, causes a lot of increased appetite and weight gain, more than the others. So do I ever use it? I use it if I've gone through 3 or 4. It can be effective, but the weight gain can be rough, the effects on metabolic measures, etc. What dose would I start with? 2.5 milligrams a day. Maximum is 20. Quetiapine or Seroquel, I don't know. A lot of people use it to treat sleep disturbances. They use it to treat significant anxiety. I can hear all that. Here, does it treat aggression? It can. It's not well studied, but I'd use it ahead of Zyprexa because I don't want to get into massive weight gain. You can see weight gain with this and sedation. What would you start it at? 12.5 or 25? I know, but you can go to 400 or 600. I know, but I'm going to go slowly. So it's one that I use. Ziprasidone or Geodon. This is the only atypical that doesn't cause weight gain. Rarely does it cause weight gain. So that means a lot in my world if the drug works. And I'm using more and more of this. I don't I might have had an initial impression that it wasn't doing much, but if you work in a tertiary care setting, you end up using a lot of stuff. I'm using more of it out of the gate now. Why? Because it seems to do quite a bit, for me anyway, at lower doses. I start at 20 a day, I go up by 20 a week. A lot of guys are getting better at 40, 60, or 80. So if I can stay away from the weight gain, I want to. I want to. Do you worry about the cardiac effects? Well, I don't give it to anybody with personal cardiac problems, or a family history of sudden death. You're not going to hear much about that. Do you get a baseline EKG? If you want to feel comfortable, you can. I sometimes, if the parents want it, I'll absolutely do it, but the FDA doesn't recommend it. So it depends, but I'm not. It's not rigid with me, but I am using it more. You have to take it with food to enhance absorption. Very important. Aripiprazole, Abilify, FDA approved. It can be helpful. You're not going to see as quick an effect as you might with risperidone because it's less sedating. Don't ever start higher than 2 or 2.5 milligrams a day. Why? Because you could get into akathisia. That's the one with this drug, in my opinion. If you start at 5, that's too high to me. 2 or 2.5, go up by that amount a week. If they're going to get better, it could be from 5 to 15 milligrams a day. Much above 15 or 20, I don't find that you're going to get much additional benefit. So I'm starting to lose effect about there. It does not increase prolactin. It lowers prolactin, so you won't get into any gynecomastia or anything like that. But low dose and akathisia. Paliperidone is just a breakdown product of risperidone. What's the trade name? Help me. Invega. It's a capsule again, kind of a once-a-day thing, so you might get into problems with swallowing. Okay, Maynard Ferguson. Do you guys know he's from, I don't know, is he someone you say, oh, he's from Canada? Where's he from?
Montreal.
Okay. I need to go there someday, don't I, Montreal? I've been here a few times, but... Huh? Winnipeg. I love Maynard Ferguson. I was a trumpet player for a while, but I wasn't good enough. My mother told me. I was first chair out of 17, but she says you're not good enough, so don't do that. All right. Thanks, Mom. I'll do autism. So, treating aggression. You'd wonder about, well, what about mood stabilizers? Because maybe they're like safer. Well, sometimes they're safer. They don't work as well. Well, what if I want to try them if I have got a little leeway? You can, but the data aren't great. So Depakote, generally the studies are negative, no drug placebo difference. Occasionally it can work. Occasionally it works when nothing has worked. I look for family histories of bipolar disorder. That will influence me. Real bipolar, not just they say it is, But generally, I don't find that it does a lot. Well, what if someone has seizures and aggression? Then you kill 2 birds with 1 stone. I like to think that way. It doesn't always turn out that way. But if it works, then that's good. Lithium, not generally. It's not generally good, unless they have bipolar disorder, It causes tremor. That's not good in these guys with fine motor. It can cause enuresis. Problem already. You got to worry about the thyroid, the kidneys, being out in the sun. I don't use a lot of it. Carbamazepine or Tegretol, I didn't used to use a lot of it. I'm using a lot more of it. Because if I want to avoid an antipsychotic and I want to use a mood stabilizer, well, the classic mood stabilizers are the first 3 listed in the way I was taught. And in my hands, carbamazepine has the fewer side effects among the 3. And I've been using quite a bit of it. I'm still using it, which tells me that it's helping a number of patients. So there's something there that hasn't been well studied that, at least lately, I've been having success with. Gabapentin, it's pretty safe, If you want to use it to treat some anxiety, you can. I don't think you're going to get a lot more out of that. Topiramate, Topamax, I will tell you that it can be helpful for weight loss in people that have gained a lot of weight with our meds. I've seen young women lose 80 to 100 pounds in a positive way. With topiramate. It can cause kidney stones. That's going to be rare. They say it can cause cognitive dulling. Don't go crazy with the dosing and try it and see. It sometimes can cause like word finding difficulties, but often I don't find that. Something to think about if the weight gain is out of control and you really can't change the meds they're on. Something to think about. Lamotrigine, I'm in a generation that hasn't used much of that. I don't treat like bipolar depression and stuff, so I don't have much experience. I never start it unless like the family really says they want to, or they're on it for seizures or something. But there is a placebo-controlled study showing that it didn't do anything for any element of autism. This is just what I've told you. So other things, you have to blood levels for Depakote, lithium, blood levels also, Tegretol. What about trileptal, right? Oxcarbazepine, kind of like Tegretol. I once had a faculty member that said to me, Dr. McDougle, I use a lot of trileptal. I said, really? Because I don't see it do much, and there's a big placebo-controlled study in pediatric bipolar that is negative. She goes, yeah, but you don't have to draw blood levels. I go, yeah, but does it work? Well, so I don't know. I don't find it as helpful as carbamazepine. Where's she from? What? Napanee? That's in Indiana. That's like where the Amish are from. No, it is. What'd you say, Valparaiso? That's where I went to college. You do? She knows where I went to college. Am I on Google? Yes, I am. Where are you from? I know all about that, don't I? I guess we're going to the Queens Street West on the train. Avril Lavigne. All right. Okay, aggression. So you saw antipsychotics, mood stabilizers. If you're getting nowhere again, or if you want to start conservatively. So you say, I just don't want to get into that. It's the first time this kid's going to get a drug. He's 4. What can I use? Can I use something relatively clonidine? So that's where clonidine, I don't use it for ADHD, too sedating, but I might want to get more calming for aggression in a young kid where I don't want to get crazy, okay? So clonidine, where would you start? Comes in 0.1 milligram, maybe a half of that. Just see how it goes. Go slowly. But at times it can help for aggression in a place you need to be a little cautious. Now, Truxone, crazy drug, blocks opioid receptors. In the old days, there were theories around opioid dysfunction and autism. They thought it could help with social impairment. Then it was a drug everyone was using for self-injury, maybe in the 80s, across diagnostic groups, borderline personality. You don't use it that much probably anymore, which tells you something, but it's one of those where I've started using it a little bit again because it's pretty safe, but I'm using it on occasion for severe self-injury if other stuff isn't working. And sometimes it seems to do something, It's worth a try, but I'm not overly optimistic. But I changed for this slide. I used to say it doesn't work. Now I say occasionally. Steppenwolf. Where? Where are they from? Maybe. Have you ever heard Neil Young's sister sing? Okay. Depression. This is interesting to me. Look, if you read chapters on intellectual disability or autism, it'll say more anxiety and depression than anybody else, right? There's not one systematic trial of depression, treatment of depression in ASD in the world literature. Not even open label, prospective. 0. So I list them the way I might think about them in treating depression in general. There's no, but that's amazing to me. Not one, not even like open label where we're just going to give them the drug and do ratings. Nothing. Adults, kids, subtype, country, nothing. Amazing. Some of that could be, well, how do you diagnose depression in a nonverbal person? That's another discussion, but it gets back to what I said before. He's going to yell at me. He's a nice guy. Oh, I have more time than I thought. So diagnosing depression in an adult, nonverbal, cognitively impaired person with depression I don't want to say it's easy. But so I look for change. That's the thing I use for when you become 18 or so, or mid-20s, there are disorders that come about in us. They can come about in them. So if there's a major change, it's going to be psychosis, depression, or bipolar disorder. Something radical. It's one of those. So you got to kind of look at sleep, look at energy, look at appetite, right? Interest, motivation, and then take your best shot. But you can't say, I'm not sure, so let me follow you. I don't know what you say. Don't be like that. Really, you're here to help people. So start then with the least dangerous drug and take a shot at it. Get out an antidepressant, and it's going to give you some answers pretty quickly. But if there's a major change, it's not that complicated. You got to go for it. To not do that is almost criminal, right? I mean, think about it. Particularly you get a family history and all that, and you get buy-in from the team, go for it. Bipolar, again, there's no studies, because there's so much cyclical behavior in what we do with these guys. It's you can call it that if you want, but don't kid yourself. Just say it's cyclical behavior, and I'm going to approach it like I do cyclical aggression. Sleep. So big problem. All kinds of reasons, right? If the kid gets out of the house at night, drowns in a retention pond, it happens. It's happened. Goes to the parents' bedroom every night. We just quit fighting it because it's harder to fight it. Well, now he's 16 and he's sleeping in between everybody. I mean, I'm not saying it's bad. I'm just telling you, it's keeping everybody up at night. Them not sleeping, behavior is worse the next day. So you kind of think about sleep relative to the other symptoms, and you go, that's the least of your worries. It could be a big mess. I can tell you the government, the National Institute of Mental Health, has no interest in studying these meds for sleep. We don't do drug studies anymore. Okay. We don't even know if clonidine is better than trazodone. The only drug that's been studied is melatonin, about 19 times. What about some of the others? So anyway, sleep. I always start with melatonin. How do you do it? 3 milligrams. If it's not better in a week, go to 6. If it's not better, go to 9. Then you're done. Over the counter. Don't stop at 3. Go to 9. What next? Well, the most effective drug I have for sleep is trazodone. Most consistently effective, hands down. What about clonidine? You can try it. It'll work at the beginning, and then it'll quit working. They're going to wake up in the middle of the night. Well, man, I'll just give them another dose in the middle of the night. Go ahead. Versus try to get some sleep. Trazodone, what dose? Slow as you want to go. 12 and a half, 25. Go up by that amount every week. To what? Till it works. What's a max dose? I don't know. 150? Right in there. We used to use 600 milligrams to treat depression, but then we were all sleeping. So what about priapism? You need to tell them about it, because if you don't, it'll happen, right? So a sustained penile erection. I've seen it twice in 25 years. But think about this. So you have a 14-year-old male, cognitively impaired, nonverbal. You always have to think about your side effects in somebody like that and assume they're going to have them, and how are they going to be able to communicate it. That's where you want to think. And here's this guy, could become a medical emergency. Here's the 2 cases I had. Back in Indiana, now I know, see, Riley Hospital, she knows. Let's see, Broad Ripple, the Alley Cat. Now I got her number, see. 5, well, I'm not a race car fan. I'm a basketball fan from Indiana. By the way, last night, they blew out Illinois at Illinois. They're 13-3 in the Big Ten, and they could win it all, but they have to beat number 8 and number 10. But don't get me started on that, or I'll act like Bobby Knight. She knows all that. I'll throw chairs. Okay. So a little boy, I don't know, he was 12. He was on sertraline. We added a little trazodone, and he developed priapism. It didn't get to any dangerous level, but it was there. The most recent case I had was within the last 2 months. And this was a kid that's really psychotic. I don't think he has an ASD. I inherited him. He's been on everything. And he's on Haldol right now, 9 milligrams a day. But he'd been on everything. And he's at least not psychotic. But he'd been on it for a year and a half. And I got a call, priapism. 9 milligrams of Haldol, been on it a year and a half. Real priapism. Go to the ER. They do painful stuff to treat that down. But anyway, it can happen is the point. But rarely will you see it with trazodone. Maybe, hopefully never. But I use a lot of trazodone. Mirtazapine, is a drug you may not think much of. Remeron. It can help with sleep a lot. It can help with anxiety. What dose do you start? 3.75 milligrams. So it comes in a 15. I start with a quarter. And that's really low, but that's just what I do. And I go up by that amount on a weekly basis. The problem here is if you get into increased appetite and weight gain, which can be an issue. But it's my number 2 drug for treating anxiety. You know, anxiety is huge in ASD, right? It's way up. So I can tell you what's my number 1 drug for anxiety? Buspar. Don't laugh, that's what I do. Correct. But I have huge success with Buspar. And I know it doesn't work for a lot of things. It works here, it can. So what do you start with? 5 milligrams, start with 2.5. Go up by 2.5 a week, alternating between morning and when they get home from the day. And, you know, go to a max of 30, usually. Won't work more above that, but until it works. It's going to take time, but it's my number 1. Rarely do I use an SSRI in my practice, almost never. Tricyclics, if you're working your way down for sleep, then amitriptyline can be very, very helpful if you're just striking out. Start really low, you know, constipation, dry mouth, lowering the seizure threshold, cardiac. But sleep, if it works, it can really make a big difference. Benzos and Benadryl can cause paradoxical reactions. I think we were trained to think that benzos almost always cause paradoxical reactions in kids, developmental disabilities, and the elderly. I think I was trained that way. They don't always. Sometimes they can be the only thing that treats anxiety. So if nothing's working, don't shy away from it. You mean like daily? If you've tried things and it's a nightmare, it can. There's no studies, I think, because people have made an assumption. I'm saying on occasion. Avril Lavigne? What? Where's she from? Ottawa? Didn't she used to date a hockey player or something? That's what all the songs are about. She's angry. Anxiety. Buspar number 1, mirtazapine number 2, but you could see weight gain. And then very low dose SSRI. You know, I don't want to say don't use them if you have success with them. I just don't. They're not in my playbook that often. Pica, nothing works. You know, eating things you're not supposed to eat can be dangerous. They're fast. It's refractory. I don't know of anything that really works consistently. This is just sort of like something to think about, but that it gets to that idea of not everything that's repetitive is OCD, all right? I really want you to hear that one. OC spectrum disorders, you can imagine what I think of that. It's a way to write a book. I mean, it makes it all nice and neat. What's so hard about it, right? Because it's not true. There's a lot of repetitive things that don't get better with SSRIs. What do you do with skin picking? You're not going to get very far with an SSRI, I'll tell you right now. It's going to make them worse. You're not going to get very far. What about this or that? No. What do you use it for? OCD. Okay. I shouldn't even say inappropriate here. I should just say sexual behavior. It's not inappropriate. It's inappropriate if we did it. It's not inappropriate if they do it. This is one place that God and I disagree, because he wasn't fair here to give these people normal human sexual function and childlike sexual judgment. That's not a fair setup. So it's not inappropriate. It's sexual behavior that we don't want them to do. But it's really not wrong. It's right, in fact. So, but it can interfere with us, you know, attacking the teachers to grab their breasts, masturbating in public, rubbing up against people, all that stuff. But it's really, they don't know any better. And what are they supposed to do, all right? So, you know, you try with redirection and education and all that stuff, and many times that'll work. What if it doesn't work? You try behavioral strategies. What if it doesn't work? And now they're housebound because nobody wants to take them to the mall. They're really housebound. Then you're into, you could try high-dose SSRIs if you want, but you're probably not going to get anywhere unless you get there via sexual dysfunction. That's fine in some ways, but you could try it. Hormonal, you know, I usually end up with oral Provera. So you've heard of Depo-Provera, the shot. Well, there's an oral form, and it comes in 10 milligram pills, and Again, I don't have a lot of experience, but if I go up by 10 milligrams every week or two, I usually end up around 100, and that seems to have helped the guys that I've treated without any negative side effects. But, if it's led to aggression or being housebound, I mean, bad, 3 or 4 times in my life. What if the oral Provera doesn't work? Then a couple times I've gone to the injection. And often that's been when the patient's an adult and for whatever reason, they're very interested in little girls. I mean, that's where everybody freaks out. And they're like, you got to do something. So it doesn't make me go faster. It makes me go farther. And I found that Depo-Provera, the shot, once, again, it's start cautious and go up once a month, once every 2 weeks, once a week, whatever, can be helpful. And while you're doing that, you're introducing all kinds of other non-drug treatments. But you got to shut it down because people are freaking out. It may not be a sexual interest in the little kids, but it doesn't matter at that point. So that's just a little bit there. Nickelback. I think he was married to Avril Lavigne. Are they divorced or married? Married? Chad what? Kruger? Where are they from? Mount Kisco? What? Probably Ottawa. Wherever, what's her name's from? I know you're nervous. What time is it? I'm lunchtime entertainment. All right. Are they going to eat in here? What if we do lunch? I'll just stand here and answer questions over lunch. And you can ignore me, but I'll be available for questions. How's that?
Yeah, I think lunchtime will be a good time. So, well, thank you so much, Dr. McDougal, for this comprehensive as well as highly entertaining presentation. I really like all those beautiful photographs popping up in between. So